All right, I am now going to turn the meeting over to our speaker. And let me.
Okay. All right. Thank you. So my name is Aamer Syed. I'm pulmonary critical care at VCU. And thank you all for inviting me to this meeting. I've already heard just kind of from the introduction some very interesting diagnoses. So and some of it will be very relevant. Um, I've been at VCU. I did all my training here. And I've been on since 2002. I've been at VCU, but we have this dedicated sarcoid clinic. I've been on faculty since 15 years, and it's a large effort. That's why I have a lot of names at the bottom of the list. It's just not me. Um, it's a multidisciplinary disease, as one of our participants already mentioned. So it takes an entire team to run this, and I'll just mention these names: Dr. Iden, Dr. Syed, H. Syed, Ms. Alderson. These are, and McLaughlin are the pulmonologists on this team. Dr. Crone and Kashiwabara, Linda Kashiwabara, are the cardiologist, electrophysiologists on this team. Gupta and Syed are the pulmonologists. Canisario is neurology, and Abdulhamid is our dermatologist. I don't have a lot of our heart failure doctors on this list. There's Dr. Patel here, who's our liver doctor. So as you can see, it involves multiple organs, and we'll talk about what sarcoidosis is. But it's been a fascinating venture for us. It's been somewhat, as I go through my PowerPoint presentation, you'll realize it can be a pretty vexing disease. But I guess that's where the challenge is, and I think that's where um, I'm in this field. So jump and please feel free to stop me. We'll try and make this as interactive as possible, and I'll be mindful of the time. So it's just a couple minutes, 8 minutes past 1 o'clock. So um, probably about um, 35 minutes or so, 40 minutes. I'll stop. But yeah, please stop me anytime. But anyway, so the question that a lot of people ask is, what is sarcoidosis? They've never heard of it. Sometimes doctors in different parts of the country have never heard of it. And it sounds kind of a unique, weird name, but really it was described by a dermatologist in the early 1800s. Basically, it's Greek origins. It just means sarx, flesh, and osis means conditions. Essentially, it just means a skin condition. Because back in the day, that's what they noticed. It was like skin lesions, the fleshy skin lesions on the face or the body, and they just called it skin condition. And over the years, we've learned a lot. And I just put up this slide up here. Kind of, it looks like kind of this oval shape, and that is the term that's we'll refer to again and again. I mean, that's a description of the cells arranging themselves in a granuloma. Okay, and that's kind of the key word in this diagnosis, and that's a very unique formation of cells, and we'll talk about why it makes it also very challenging. And just for folks to know, it is a rare disease, but a lot of we're surprised a lot of times, and I'm still surprised every time I learn more about. Some famous people have this disease. Reggie White, of course, had cardiac sarcoid. Football player. The King of Netherlands has sarcoid, and actually, Scandinavian countries have a lot of sarcoidosis. And of course, Bernie Mac, that a lot of us know, passed away from complications of sarcoid. Karen Duffy is an actress, author, and Amelia Fox played a role in The Pianist as well. She's a British actor, and many more. I just kind of put up just kind of a representation of folks that we may not know that have sarcoid. But anyway, so the idea of what I'll go through, it's pretty extensive disease, involves so many organs, but I'll try and encapsulate is what it is, what the challenges we face, what organs it involves, and how do we manage it, right? Um, One of the challenges in sarcoid is early diagnosis and recognition, because it's a very treatable disease, and it's inflammatory disease, which some of you may know, especially lung diseases tend to be environmental based a lot of times, right? Smoking issues or environmental factory type work or aerosolized exposures, or infections even, right? So the challenge with sarcoid is that it can mimic any of those diseases we talked about. Like, common presentation is cough, congestion, you go to your doctor, you get some antibiotics, some steroids, you feel better for a little bit and it comes back. So one thing that we're trying to increase the awareness, because it's surprisingly very prevalent in Virginia. So we actually are probably the largest center in the country. We see about roughly 3,000 patients a year. And as I've seen the doctors that are listed, we have like 8 doctors doing more than 70% of their clinical time just doing sarcoid. And that's all I do now for the last 10 years, no, actually 12 years now, dedicated. That's all I see, up to 40 to 50 patients a week of sarcoid. So it's very common in Southeast. And the question we've asked ourselves is, why is it so common here? When I say Southeast, it's involved, North Carolina, South Carolina, and Georgia as well, and quite a bit in Maryland. So there are a lot of theories. It's humidity, moisture content, aerosolized content. Despite 40, 50 years of research, we still don't have a clear answer as to what causes this inflammatory process. Okay. I'll just go back 2 steps back up to the initial slide, because I'll center back on this pink cellular tissue that you see. It's the granuloma, right? So our human body, if you think about lungs, and that's why we see so much lung diseases, is lungs is not really an internal organ. I call it, I'll tell my fellows and residents, if you think about it, it's actually an external organ outside our body, really, because it's constantly interacting with everything in the environment, right? Air goes in, air comes out. Everything else, the heart, the liver, other internal organs, except of course our GI tract, uh, everything is encapsulated in nice little packaging. So it's protected from the outside environment. So the body has to, similarly like our skin, it has to create a defense. So the lung tissue inside are full of these immune cells waiting essentially on the wall, and their job is to identify foreign, or not, let me take that back. Harmful or not harmful. All right. So every little particle that you breathe in and out, like you're breathing right now, your macrophages, a type of immune cells in your body, are constantly picking them up, looking at them, saying good, bad guy, good guy. Right. And if it's a good guy, they ignore it, like a piece of pollen falls down into your lungs and people don't have allergies, nothing happens. There's no reaction. But if it's harmful, say a piece of bacteria or virus falls down, the immune system, the cells say, okay, we need to take care of this guy, right? But in sarcoid is unique in the sense that the same cell, it's a harmless cell or a harmless particle, let's say a piece of dust, floats down into your lungs. These cells, the macrophages that I talked about, pick up the cells and say, bad guy, call it a bad guy, and, you know, start the alarm bells. So the immune cells, as you can see, flood into this area and encapsulate it and then try and kill it. That's the natural defense. But the problem is they can't kill it because there's nothing to kill, right? It's a piece of silica, inorganic particle, it's not going to die. So they pour chemicals, nitric oxide, all that stuff on it, all the noxious chemicals to try and kill it. It doesn't die. So the immune cell says, hey, man, I can't kill this piece of silica or particle. I'm going to surround it and wall it off. And hence, this oval shape that you see is basically it's surrounding that, what it perceives as a harmful particle, to try and protect the rest of the body. But the problem is, it still is trying to kill it, right? So TB, right? Tuberculosis, that's how a body handles TB. Now we don't see much of it, but back in the day or in other countries, still you see a lot of it. Is it's hard to kill normally, so the cells form a cage around it and kill it, right? And those are known as caseating granulomas, meaning caseum, meaning curd-like, meaning there's necrotic debris, pus, all that stuff. In sarcoid, there's no pus, there's no debris because there's nothing to kill. So it's called non-caseating, meaning no pus in this granuloma. But the problem is the immune cells are still revved up, upregulated, and because they're desperately trying to kill this non-living being. And the surrounding cells become all inflamed, and inflammation is the problem, right? As you all know, in other diseases and in general health and all that stuff. So inflammation causes damage. Inflammation causes fibrosis. A simple, very simple example is, say you get cut, right? A little brew. You cook in the kitchen, a drop of oil falls, or you're doing something and you get cut. There is inflammation, i.e., because the body is now trying to repair itself, pours in fluids, lays out some cells, maybe pus may form, pus may not form, and then scar tissue. The problem is the same scar tissue forms inside the lung, not repairable, right? Causes causes disability, causes all sorts of issues, oxygen, breathlessness, and everything. So that, in a nutshell, is the problem with sarcoid. So just kind of quickly, it's a little background. Sarcoid is fairly rare across the globe. As you can see, it's about rough numbers, about more common in women, about 16 per 100,000 in men and 19 per 100,000 women. And in the U.S., predominantly African Americans is where it's prevalent in, and like I said, Southeast U.S. the largest numbers are seen. So, and it's also rare before adulthood. I mean, it's kind of that prime 25 to 45 is where it presents. Um, and then we also see a smaller peak later on and more prevalent in women. I'll show you some kind of like studies done here in the US. Access trial, this was done, in the late 1990s and presented in 2000s, this was what done across the US, where it shows that predominantly there were more Caucasians in this group, and of course with higher prevalence of females. But this is where I think VCU is a little bit different, or the Southeast is different, because we question this data, saying that, hey, we're not seeing this. We're not seeing more Caucasians than African Americans. So we did our own study, and since have expanded it considerably, this was like an early dab at our data set. And as you can see, 70% of our population is African American females, and roughly about 30% or so are non are Caucasian or non African American populations. So it's an interesting distribution. Um, but if you go to Scandinavia, it's as you know, it's predominantly Caucasian population, and the prevalence is very high in Scandinavia. So it's interesting because we thought maybe it's kind of like something to do with genetics, something to do with African Americans. That's why we see such a high prevalence, but it doesn't bear out with the data sets that we see across the world. So that's kind of a little bit of background, the prevalence, and kind of the distribution of sarcoid. But we'll talk about this is where it makes it so challenging for us, right? If you look at the list that I put up there, it's fatigue, cough, shortness of breath, right? Anybody with lung issues will have that, right? So it's like, how do we distinguish one from the other? And this is the problem with sarcoid, is where a lot of patients present to us a little bit later in the game. In other words, if you kind of go back to what I was saying in the beginning, that persistent inflammation, okay, that can happen in and I'm sure you have, being Breathmatters, I'm sure you've heard from or have, other inflammatory conditions or pulmonary fibrosis or even COPD, emphysema, all of that stuff. If you think about, the pathway is the same. I mean, we think about these diseases as different things, we put labels on them and so on and so forth, right? But the take home point is, if there's an external insult, i.e., you smoke, particulate matter, or inappropriate, behavior of the body, i.e., misidentifying harmless particles as harmful, it causes inflammation. Unchecked inflammation leads to scarring, i.e., fibrosis, right? And that can happen in any organ of the body, like people like cirrhosis, right? Liver cirrhosis, liver fibrosis. Same thing. Say if you're an alcoholic, you drink a lot of alcohol, alcohol causes inflammation, the body tries to fix it, repair it, because the body is always trying to achieve homeostasis, meaning come back to the normal state, despite whatever insults we throw at it, right? Same thing with emphysema, COPD, right? I mean, the lung gets damaged because it's trying to heal itself and it can't. The healing mechanism fails and you get lung damage. So the take home point is, insult, inflammation, unchecked inflammation, don't catch it early, leads to scarring, permanent damage, you can't fix it. So, so as you see, fatigue, cough, shortness of breath, patients show up all the time. They go to the primary care, go to the general practitioner, whatever it is. Here, you've got a little bit of bronchitis, so on and so forth, and go on your merry way. But the problem is, when we treat them in episodically, the underlying fibrosis continues on. By the time they've gotten so bad that they present to us and are like, well, okay, you've got serious lung disease, you've got fibrosis. I don't think I can reverse it. I'll do my best, right? If there's any more inflammation, I'll try and shut it down. And then the other list of items that I have at the bottom are, and some of you might have experienced this, is like, the cardiac ones, palpitations, heart block, syncope, passing out. It can affect the joints, affect the eyes, affect the skin, affect the brain. And then Lofgren syndrome is kind of like this was described again in the late 1800s. I think everybody back when you describe something, you put your name on it. Dr. Lofgren did it, I think. So you noticed in the rash, you had some arthritis and you had enlarged lymph glands, either in your neck or chest. Um, but this incidentally, fortunately has a good prognosis that sometimes this particular syndrome, the immune system is smart enough to say, okay, you know what, guys, cool it off. We don't have to go crazy and cause persistent inflammation. Let's shut it down. And that's what happens in sarcoid too. Here's just one of my colleagues, Dr. Eidenhead, uses this every time. That's his favorite. So I stole it from him. So it's just kind of a quick idea of what organs are involved. As you can see, lungs predominantly, 90%, because we think the route of entry of this potential pathogen is the lung. And lung sets off this inflammatory cascade that can affect other organs. Um, you know, and these are rough percentages. Neurosarcoid was considered rare, but we see more inflammation in the brain. Cardiac, we very actively manage a lot of cardiac sarcoid. And eye, liver, and pulmonary hypertension, which you might have heard from a lot. I work very closely with the pulmonary hypertension team here. We can see that a fairly, the numbers are still, it's a big range because we're still learning more and more. We're actually not learning, we're recognizing it more often now with in our program. But as you can see, it's highlighted because that tends to have poor prognosis um, compared to other manifestations. I'm going to just show this here. This is kind of the same thing. This is, again, our database where we went back and looked at it. And it confirms what the numbers are, what's published. Pulmonary tends to be the highest, 90%. Skin is 20%. And at this point, which is an actually interesting point, you see I only showed 3.9%. This is when we actually collected this data set when we started a program, okay? And what is interesting is, it is what a program, a multidisciplinary program does for us is we've increased these numbers of cardiac numbers about close to 20% is because early recognition, right? Because we're looking at this disease state in a very, very organized manner. I'm going to show this slide here. Just a little bit background on our clinic because of a quick pause. It's a large team that runs this. We established this in 2014, and it's recognized nationally. I think there are about 30 centers now that are recognized as this WASOG sarcoidosis clinic in the world now. And then we offer a combined program essentially. And like I said, we have about 3,000 patients we actually actively manage in a program. So why is this, like I said, a diagnostic challenge for us, right? So like I said before, most half the cases, 50% of the cases are not diagnosed because cough, shortness of breath, right? We're not going to think sarcoid when somebody sees that for the first time. So it takes a while and it takes a lot longer before they get to us. And a small number of patients takes 2 to 3 years before they actually achieve the diagnosis. There isn't a specific test, unfortunately, like a blood test. There was this ACE number we were looking at one time. We thought, when it came out, when we discovered it 30 years ago as sarcoid researchers, we thought, yes, that's like our, A1C that you see in glucose, your hemoglobin A1C. We haven't found a number or a PSA, for instance, right? So it is really a diagnosis of exclusion that we have to work through due diligence of ruling out other causes. And I'll kind of get into that a little bit. It's essentially kind of a just quick outline. Somebody comes in, cough, shortness of breath, whatever it is, we might get an X-ray. X-ray, and I'll show that to you in a second. X-ray might have this very classic look. If there's a location that we can biopsy, and then a biopsy alone doesn't confirm the diagnosis of sarcoid because many other things, not to complicate our life. Remember the granuloma show I showed you that has this classic look? There are about 50 other disease states can cause the granuloma, right? So we're like, okay, what is it now, right? It's a granuloma, sure, big deal. Can I call it sarcoid? And that's what I'll kind of try and kind of highlight a little bit as we go down our list here. I'm just going to scroll up a little bit. So this is an X-ray here, and you'll see stages, stage 1, 0, 1, 2, 3, 4. Here, the staging in sarcoid, it doesn't have the same like stage 4 sarcoid, right? Stage 4 cancer is a different beast. It doesn't mean that you've got cancer everywhere and you're about to die or whatever it is. Here, staging came about back in the 1950s when Dr. Scadding in England didn't have CT scans, and he said, you know what? He followed these patients as he got X-rays over time, and noticed that patients who had scarring, which again comes back to the point that I made earlier on, they were simply given the diagnosis. We were classified as stage 4 sarcoidosis, meaning that scarring, meaning it was not reversible. So what it just says is stage 0, okay, normal, right? Stage 1, if you've got lymph nodes, and actually, I don't know if you can see this, it's kind of it's a chest X-ray, and it's a black and white film, right? Chest X-rays. Black means air in our X-ray, and you see those ribs, and everything else white is, solid object, right? Bone, muscle, whatever it is. In the middle of the black area, you see these kind of hazy gray areas. Those are lymph nodes. And what it basically tells is stage 1, you've got lymph nodes. There's a high chance of resolution of the disease. And similarly, if I kind of go down to this one, you see less of black, more of white in the lung fields, right? Where it should be all black. That's basically pretty significant inflammation in the lungs. And I'll kind of jump one here and I'll show you this. This is stage 4, meaning that the same inflammation unchecked has turned into scar, and I can't do anything about it. So staging just tells you in sarcoid the degree of lung damage, not necessarily prognosis. This is a CT scan. It's basically a You might have seen CT scans of yourself or other CT scans. These are like cross sectional slices. This CT scan doesn't tell me when I look at it. Again, this is black as air, white as solid, right? So I'm just going to put my cursor. I think you can see my cursor, right? The cursor here that I'm showing, this should be all black, all black. You see all these kind of those white patches. It just means there's something solid in the lungs. But my problem is when I look at it, I can't tell this is sarcoid. It could be anything else. It could be, some kind of fibrosis or some kind of infectious disease. So it's not a very classic finding. And here, essentially, this is the same thing, but this is just more scarring and damaged lung. So kind of coming back to making the diagnosis, we get imaging. Yeah, it looks like something. Uh, I'll tell you, our we see so much sarcoid that normally when you get an X-ray or a CT scan and you see like a lung mass, most doctors will say, "Hey, it's cancer," until proven otherwise, right? Our perspective is so skewed that we think it's sarcoid until proven otherwise, because surprisingly, it's that common in our region. So yeah, so we can biopsy, right? The next step is we'll try and get the easiest site. It doesn't always have to be the lung. Remember, this is a multi-system disease, right? So it could be in the skin, lymph nodes, anywhere we can get a piece of tissue which is easily accessible, we do that. And this is what we look for, like the granuloma I showed you, that oval shape with the kind of the purplish cells in the middle. And that's the term non-caseating, meaning there's no pus or no curd like granuloma. So this is, it doesn't have any pus cells in there. And then we make sure there's no infection to rule out infection and all that. But now this is the problem. Okay, like I said, sure, you got the biopsy, you're happy, it looks good. But then you have to think about all of these other things, that all of these list of items, right? Pneumonitis, metal exposure, people who do machining work would work with these metals, silica talc, some cancers, um, and then Crohn's disease, some kidney disease, vasculitis, infections, some funguses, mold, all that stuff can look like that. And this is where we struggle in saying, I just can't say, okay, you got a non-casein granuloma, I'm going to call it sarcoid and walk away, take this prednisone or whatever it is, or treatment is. Let's say, I'll bring up prednisone in a little bit. But say if I gave you prednisone, if you've got an infection, I can make your situation considerably worse, right? So this is where we use a large team of doctors. It's a team sport for us. So we might reach out to my ID guy, I might reach out to my liver guy, and say, we kind of have like these meetings saying, what do you think this is? Are we 100% sure? Have you ruled out other diseases? And part of it is from the patient history taking and stuff, right? Say somebody who's never worked with, always had a desk job, never had any aerosolized exposures and all that stuff. We kind of have to do a very detailed review of systems, so to speak, to make sure that we're not, putting a diagnosis too early um, um, before we're ruling out other stuff, other disease states. So this is what we say: the diagnosis of sarcoidosis is never confirmed. It is only kind of excluded other diseases. So I'll put this up here for you. It is, I saw this years ago. I saw this quote by Russell. It's so true of us. And this is where we struggle with. The demand for certainty is one, which is natural to man, right? But it's nevertheless an intellectual vice, because in the sarcoid world is we deal with uncertainty all the time. So anyway, this is what we've suggested to folks. Like, you get an X-ray, get a cardiac history, get an EKG, get an eye exam, and get some, blood work and lung function testing to give us an idea of where things are. And then treatment, right? Now we come down to treatment. Say you've got symptoms. Say you've got declining organ function. Say your heart function is declining, your lung function is declining, or your vision's declining, all those organs, various organs, then there is an indication for systemic therapy. But we also, in our mind, we triage what is high risk organ manifestation, right? So in that, and this is really consensus. There's really, it's all 30 years of, knowledge that we've gained is like cardiac, CNS is brain, or central nervous system, and eyes. Those are the three organs when involved. We tend to consider treating earlier than later, sooner than later, because the manifestations, say you've got cardiac conduction issues, arrhythmias, suddenly you have a misfiring heart block, chance of dropping dead are high, right? So we don't, lungs surprisingly are very durable organs because, again, I say it because they're open to the environment all the time and they can tolerate a lot of insult before they fail. But some organs have a very little threshold for starting treatment. I'll put this up. This is kind of a great example of saying what happens when untreated, when disease goes unchecked or untreated or under recognized, maybe that's probably a better word, is on the left side of the screen, you'll see, same thing, X-ray, right? And the lung fields, like I said, should be black because, or blacker because air, and they seem to be hazy grayish. But if you go and treat it and the patient's having symptoms, the lungs clear up. And you can probably tell a difference on your screen. The lungs are kind of more black and have the less hazy whiteness in them. And untreated, and this is where we see a lot, is, and this is a CT scan, it's a slice. So it's not apples to apple, but it basically, we put this up to show all those little holes that you see in the lungs in the lower image. That's all scarring. That's all damage from persistent inflammation. And then, and this is what we kind of think that this is what's going on, is that it's kind of tip of the iceberg is where it's a very, very, what do you call it, insidious occult disease where a lot of the presentation could be minimized or symptoms could be minimized or the symptoms are so subtle that they don't go recognized till um, you have pretty significant manifestations, irreversible manifestations. So you could have low level activity throughout. And that's kind of the challenges we have. So, and this is where our treatment um, um, dilemmas that we deal with. Okay. So the treatment is not benign in sarcoidosis, right? So immunosuppressives. Immunosuppressives can range from, steroids, prednisone, all the way to like cancer drugs, right? So they're all some form of immunosuppressives. Prednisone, we we I think are is has a too good of a reputation. I think prednisone is probably one of the most harmful drugs. We have a love-hate relationship with it because it works fast, makes people feel better, and reduces inflammation. But long term, and some of you may deal with it, diabetes, osteoporosis, cataracts, glaucoma, all that stuff. So any treatment that we use is not benign. So first of all, my question is, before I even initiate treatment, is can I not do any harm first? In the sense, do I really need to treat this patient? And once, if I decide to treat the patient, um so it's a kind of a balance for me, like, okay, if I just sit on the sidelines, am I going to let the disease do more harm, or am I going to do harm with medication? So that's a balance that we kind of have to think about all the time. And this is like a nice slide that one of my colleagues had made, in the sense that sarcoid treatment, right? So it's kind of on a scale. What is the disease activity? What is the risk of organ damage? And if there's scarring or there's suggestion of scarring, how much of I can I reverse it and return back to full organ function? And then I have to balance that with like my side effect and toxicity of the medications I use. So that's kind of something that we always weigh in. So treatment decisions, right? Assessment of disease activity. We wish we had like a blood test, a biomarker would say, you know what, your diabetes is under control, not under control, right? Similarly, sarcoids under control, not under control. We don't have a number lab or lab to look at. We have testing. Testing's not cheap. CT scans, PET scans, all of that. We use them, but they're invasive. Lung function testing, as some of you might have done, and all is not easy to do every time. So those are things that still we struggle with. So we go with a lot with symptoms, right? So symptoms and say declining organ function, say cardiac, right? For instance, heart function is declining, or there's a lot of arrhythmia or irregularity of the heart signals or heartbeats and stuff like that. Then they would say, you know what, I think we need to treat. And like I mentioned before, cardiac, you know, CNS and ocular sarcoid are high risk organs. And this is one case that we actually had, and this patient passed away. This is a young man with a beautiful family. There was nothing. Patient dropped dead, right? So we kind of, no, actually it didn't. Actually went into a heart block, passed out, rolled into the hospital, all sorts of testing done. Heart function was so poor. Um, and then got devices and all that stuff, defibrillators, pacers, all that. But I'll show you this example here. This is kind of the follow through for that, right? This is these are the common causes: heart block. You can have arrhythmias, you can have congestive heart failure, um, and sudden death may be the first manifestation of disease, which is concerning, right? That's why we treat it as a high risk organ. And this is a slice through your heart, okay, cross sectional slice. And the normal heart muscle, because of blood or heme iron, has this dark brownish. This is preserved tissue, but you see all this white tissue over here. That is all dead tissue. That is what I'm talking about. This is scar tissue that unchecked inflammation from these granulomas ended up causing all the scar. And this is where, in the scar tissue here, under that, in that wall, is where your wiring or your conduction system runs. And you can imagine once everything scars down, the conduction system is gone, and suddenly your heart muscle is not getting any signals, right? And sudden death, essentially, maybe the first manifestation that you see. This is kind of a busy slide, but basically it talks about the symptoms that we look for. That we actually see conduction abnormalities in about, it's a huge range because it's hard to quantify, but 12 to 60%. These are bundle branch blocks, meaning the signaling going to the right and left side. Um, and this is Dr. Crone, my colleague, had looked at this data that in up to 17% of the patients, sudden death may be the initial presentation, which is pretty scary to think about. So this is what we do in our clinic, and like I said in the beginning, initial diagnosis was about 3%. Now we see about 20% of the patients with sarcoidosis. Anybody comes through our door, they have breathing problems, eye problems, whatever they do, we always make sure that we screen them for cardiac involvement, because the implications of missing that are pretty significant. And we use different modalities. I'm just going to put these up just for you for familiarity. We use a fair amount of cardiac PETs. So it's a PET scan, positron emission tomography. It's used a lot in cancer studies, but we also find it's very useful in cardiac sarcoid. So this is same, that cross-sectional cut. Everything generally looks maroon, but you see those yellow areas. So that's where it shows inflammation. That's a radioactive dye that goes to cells that are active or inflamed. And hence, this patient has some inflammation in their heart. And that's how we can tell. And this is an MRI, a heart MRI. And the arrows kind of point out this is a great test. It doesn't show active inflammation, but it does show scarring. I'll show you this image. Remember that little slice that you saw? Actually, this is a better one on this side. The tissue slice that you saw just a little while ago, which, yeah, here we go. You see that, right? The white, that's all scar tissue. You can actually non-invasively see that. You see the white areas there, that's all scar tissue. And it's a significant amount of scar tissue on this patient's heart. So a couple of things. First thing we do is we have to secure the conduction system, and this is this is an X-ray again, right? So this is a defibrillator or the pacer. Dr. Crone, my colleague, or their team will put in a pacer, and this is just basically parallel wiring to take over the existing faulty wiring, right? That's all. It's electrician's job, and they run a second set of parallel wires so that the native conduction system is failing or failed, so it doesn't depend on it. So the heart at least have a secure system, a secure conduction system, and then we continue to figure out the treatment, tamping down inflammation and stuff like that. I'd mentioned early on Reggie White. He always had, which we didn't know for a long time, that he had an irregular heartbeat and all that stuff, and then he had a cardiac arrest at home, and we think that is likely from sarcoid of the heart. So take home points just to kind of, because we talked a lot about it, sarcoid, cardiac sarcoid specifically. It can cause heart block, it can cause arrhythmias, and cause heart failure. We always screen all the patients for cardiac involvement. Um, and um, and then so it's a challenging diagnosis because it's not easy to see or pick up on. So we keep a very high threshold or high suspicion for that. So again, kind of we talked about, can we reverse the disease state? Kind of coming back to the earlier slide is risk of organ damage, and then balancing things out. And then just a quick couple slides. I'm almost kind of toward the end of my talk is um, treatment, immunosuppressives, prednisone. We do a first line prednisone because prednisone, like I said, we love it, we hate it because it works fast. It gets the tamps down inflammation very quickly. And then we always have to outweigh benefit of therapy. And once we get control of the disease, we're layering, depending, a bunch of second line and third line agents, and I just put these names up. Some of them have their history from, or their origins rather, in cancer therapy, like methotrexate, still used in lymphoma, but these are anti-metabolites, meaning that they actually impede cell multiplication, i.e., reduce those inflammatory cells. But as you can see, the reduced cell multiplication that can affect other organs. But at the low doses we use, we see complications or side effects at about 1%. Usually it's like nausea, diarrhea, hair loss. And then we monitor the labs very, very closely. Um, this is just an example. Sometimes we use, you might have seen Humira in commercials and all. This is just an example as a third line agent. Skin lesions, this is really essentially what the doctor first saw back in the 1800s and called this sarcoidosis, skin condition, fleshy lesions. And this is a patient just we had, we're able to treat, and then inflammation kind of resolved fairly nicely. And this is kind of where we just put up our 4 pictures. This is a founding member. This is Dr. Crone, our EP doc. This is other pulmonologist, that's me, and this is my wife, who's a rheumatologist. So we have and then the other doctors that I mentioned, who have since we've added on to build to build a program, and that was the nidus of our clinic because, as you have seen, sarcoid. We need quarterbacks for sarcoid as doctors because there's so many organs involved. And I'm sure you've all experienced where you go and see a doctor, a specialist, and then it just passes on to the other specialist, and then you're like, okay, how many doctors do I need to talk to? So here we pull all the doctors in one place. At times we might see the patient at the same time, like Dr. Crone and I might just step into the room together, so the patient knows exactly what I'm talking about, what cardiology is going to do, and then we make a plan together at the same time. Um, so that's kind of in a very very rapid fire a summary of what sarcoid is and how we manage it. Um, so that's my story.
I'm sure there are questions, and I'm going to hand the mic to anyone that's got a question so our speaker can hear.
what percentage of patients does pulmonary sarcoid progress onto fibrosis? And
That's it. Go ahead, please.
Yeah, I know.
Okay. Yeah. So the question is actually a very controversial question, and it's very different from, say, IPF or other kind of fibroses. And some of you may see Dr. Paralis in our clinic for pulmonary fibrosis. Our take is if a patient presents to us early and is on appropriate therapy, there's absolutely, our goal is no patient progress to fibrosis. Okay, because it's a complete, if we tap down the inflammation, we're stopping the fibrosis. Okay, but in our population, we see almost about 30% of patients with early presentation is fibrosis. So we think, I don't think it's a genetic disease state or a feature of the disease that everybody with lung sarcoid should progress to fibrosis. And that's what I tell my patients. One of the first questions they ask me is like, hey, I've got sarcoid and stuff. Am I going to, get fibrosis and die from it? And my thing is, as long as we can treat you and, in a timely manner, there should be absolutely no reason for fibrosis. But that's our take. But on an average, we see about 30% of our population have fibrosis.
Thank you.
So, Dr. Syed, thank you so much for this talk. This has been extremely interesting. And I think my husband has seen everyone but you. And your wife, Dr. Perrin and Dr. Ives. But it's a wonderful team, and I love that multidisciplinary approach because that makes the patient feel a whole lot more comfortable as well. And everybody hears the same information at the same time, which is wonderful. My question is around Virginia. So we see a lot of sarcoidosis, and we also see a lot of idiopathic pulmonary fibrosis. Any thoughts on that?
Yeah. So this is all conjecture anyway on my part, because we've kind of looked for a cause, and this is where I think we have landed on. Sarcoid, it should be really a plural, sarcoidoses. And why I say that is, I think it's a grab bag of triggers that lead to the final product, i.e. this granuloma or sarcoid, right? So what we have theorized is this, is first of all, we see a lot of patients with sarcoid. And so we've looked at, what is the relationship with that sarcoid and environmental triggers? Can we see a trigger, right? So the closest we have come to is that well water, living in a rural area, coming of well water is a factor. Living close to farming communities is a factor. And we see a lot of mycobacteria in our soil. And mycobacteria is a harmless bacteria that is everywhere, but it's especially prevalent in the groundwater in a region. And the mycobacteria acts as that trigger. It's not an infection. It is the human body recognizes and says, oh, bad guy, try and kill it, and sends off this inflammatory cascade. So environmental exposures, because of the humidity, high humidity content, a lot of rural exposure, factories, plants. So we've seen clusters, right? I have 20% of my patients come from the Roanoke area, right? From Southwest Virginia. That's a huge number of patients because a lot of them are rural. But then again, one could argue, I have tons of patients who have never had any environmental exposure, been in an office all their lives with no well water and no mold exposure. We see sarcoid as well. So the answer is not clear. There's signals, but we think, almost convinced that there are multiple triggers that lead to the common pathway. And I think same with IPF. I think same with IPF. And as you've seen, it's kind of like Dr. Perales does a lot of IPS research, and which is a curious skewing of population because his population is mostly male and Caucasian, you see? So there may be I think there's a genetic predisposition. So in the end, what we've landed is two-hit theory. One is you have a predisposition, genetic predisposition to your immune system misbehaving, and then you get a second hit. The second hit could be environmental, or it could be internal as well. We've seen that in patients, um, which is first time when we first saw this, like start seeing this about 10 years ago. Patients have, some of my women patients have had breast cancer, right? Breast cancer treated, all done, no sign of cancer everywhere, anywhere. And they get their screening scans or CT scans or mammograms or whatever it is, and enlarged lymph nodes. They're like, oh my God, cancer, breast cancer has come back. And we go and biopsy those enlarged lymph nodes, and it shows these granulomas, sarcoid like reactions. So, what we have seen that is in cancer, treated cancer, that the proteins, the cancer proteins or the chemicals from the chemotherapy set off the same reaction. So sorry, my long-winded answer, but that's a great question. We don't have a clear answer. We're just seeing signals, but the take-home point is I don't think there's one trigger.
Any other questions? Now is your time.
Dr. Syed, I just have one question. On one of your screens, you talked about spirochetes being part of the potential triggers or whatever. Do you associate that with Lyme disease, or are there other things that you would associate that with?
Man, you guys are asking such wonderful questions. Yes, absolutely. Absolutely. So the Lyme may be treated, right? I mean, you get put on doxycycline or you catch it early, you get treated and stuff like that. But I don't think we eradicate the entire, because the cell wall, right? I mean, it's a complex organism. You might kill it, but there may be cell wall fragments running around, and the immune system is always on lookout for these, invaders, picks up on it and says, "Whoa, call the troops. This is harmful," and then try and kill it when they can't. So yes, same mechanism applies. But yes.
Thank you.
Yeah.
Sir, at the beginning of your presentation, you showed a lot of statistics. Would you say that the disease is growing or shrinking?
So I don't know if it is growing. We just seem, and it may be, but what I can say with certainty is we are identifying it more. We've gotten better at identifying. And see, there's always a center bias, right? Because at our sarcoid program, we go looking for it. If you go looking for it, you're going to find it. Like that cardiac sarcoid data that I presented, right? So our numbers have gone up from like 3% of identification to 20%. I don't think cardiac sarcoid is more prevalent now. I think we're just doing a better job of recognizing it. So one of our projects, we were not successful. So we had not lobbied, we had put in a grant with the NIH, and of course that's a different story. And then with the local state health departments and stuff, is to create some kind of a outreach program where we can act as a support to regional doctors, right? Primary care or local pulmonologists, and act as consultants so that we increase awareness. Because for me, the biggest frustration in sarcoid, some diseases, right, cancer and something like that, you have it, you do your thing, but this is an imminently treatable disease that can prevent progression. So yeah, so short answer is I think we're identifying it, Matt. There's a little bias because of a center, we're seeing a lot more. I don't have the answer. Is the numbers increasing? One could theorize it is because aerosolized material is more in that environment, microplastics, all that, et cetera, et cetera. It may be, but I don't have a clear answer to that. So I'll tell you one thing though, which is kind of somewhat in a way tragic in my line of work. It's also a big health disparities issue in our environment, where I've had, at least for the past 5 years, I've had several young patients, 40s, 50s, die, and I could predict the trajectory 5 years ago that they're going to die or something bad's going to happen. And not because of their disease state, because of their lack of access to care. We know you've got sarcoid. I'll sit down with this lady and say, she's 40 years old. Hey, ma'am, I know you've got sarcoid. It's not great, but I can treat it. I can kind of, do everything I can so that you'll have some function of life and, relatively normal length of life and, quality of life. But access to care, being able to, like a health insurance, right? I'm sure you all kind of deal with it. Lack of insurance, lack of affordability of medications, and they stop taking their meds. They can't afford to fill the meds. They've lost their insurances. And every time I see them 2 years later, it's like, good God, your lungs are like Swiss cheese. What am I going to do? And then I hear from my coordinator that the patient's passed a couple of years later. So healthcare, health delivery, right? And it applies to a lot of the diseases that we see is, I'm kind of veering away from the mechanistic basis or the science of sarcoid. I think it's a public health issue. It has to go hand in hand. And in a disease like sarcoid, we need to have a strong public health system. Same with hypertension, right? Cardiac disease, all those things apply, right? Stroke prevention, all that. It's about having that basic primary care and accessibility to medicines that we prevent the progression of the disease. And I think it's very much so exemplified in my line of work.
Do you have any type of ongoing education for people to be a little bit more aware of this? Would that be of any help? Do you by chance, do your team by chance offer anything like that?
Yeah, we've done it, but episodically though. You again a great question. Awareness has to be increased, and that's part of it is also time and support from our institution or from healthcare institutions or organizations. We've done it intermittently. We've done some talks at Ginter, and this is, remember I was saying, we try to put in a big grant through the State Department to actually increase awareness on a statewide level. Sarcoid, and it doesn't kind of, like cancer, it doesn't, has that impact. But yeah, so again, to answer your question, we'd love to do more, and we haven't done enough. But I think it's also a resource limitation, resource and time limitation.
Good point. Good point. Any other questions? Okay, I don't want to let him go, but your time is of great importance to us. We appreciate it. And I could just sit here and listen to you a lot longer. Your message has been powerful, and thanks for your time to share it. Okay.
No, thank you very much. You guys thank you for the opportunity, first place. And you guys are on top of things. Your questions were fantastic. Questions that, people would ask at our medical conferences. So thank you.
All right. Have a blessed day.
Thank you very much. Thank you. Bye.
Bye.